topography. Now I'll start with case number one. Case number one is a patient who is a 30 years old male. He has a stable refraction. He has type 1 diabetes mellitus under control. No family history of keratoconus. Eye exam within normal limits, including ocular surface, IOP, and dilated fundus exam. The mesopic pupil is 5 millimeter OU. This is his corneal topography. This is the refraction first. The right eye is -2, -1 at 180. The left eye is -2, -1 at 5. So as you see, it is like mild refractive error. And this is the corneal topography. This is the right eye and following the left eye. I'm going to highlight very quickly the findings in this very normal topography. The average K is 43.4. There is no inferior superior asymmetry. There is no skewed radial axis. The elevation maps are of the thickness map is normal, and the thinnest location is 544. This is for the right eye. And for the left eye, although there is a hotspot, inferior hotspot, but this is very normal because the difference, inferior superior difference is less than 1.5 diopters. So the average K is 43.5, and there is no inferior superior difference. There is no skewed radial axis. The elevation maps are normal. Of course, we have to concentrate to be in the best fit sphere, 8 millimeters. And if we are studying the best fit toric ellipsoid, it should be in 8 millimeter diameter as well. Now, regarding the corneal thickness, the pattern is normal, and the thickness of the thinnest location is 551. Now, the question to the panel, is this patient eligible for refractive surgery, especially that he has diabetes? So what do you think? The question is open for the panel.
I think, Dr. Mazen, can I go for?
Yes, sir, you can go.
Yeah, okay. Studying all the 4 composite maps, I think everything is normal. The thickness map is okay, it's concentric. The thinnest location is 551. So with this thickness, you can do all the available refractive procedures. You can do PRK, surface ablation, I mean, LASIK or SMILE. If you look at the refraction, it's -2 and -2, -1.
Yeah.
So the spherical equivalent is 2.5. So if you deduct from the K1, so still, I think it will be 40 or something like that. So you are within normal, within the acceptable K after post-operative acceptable K. If you think of surface ablation, it's okay because the thickness is okay, reasonable with the refraction. But what I'm worried about is that the patient is diabetic. Diabetic patient has a problem with the epithelial healing and liable for infection. So I may cancel the thinking of surface ablation. Then we go to another option. If you think of LASIK, you have to calculate the PTA. So if you think of a flap of 120 or 130, plus the ablation, the total refraction here is 3 diopters.
Yep.
So 3 diopters.
45 microns if the optical zone is 6.5.
6.5. It's okay. I think the mesopic pupil is 5. So you can do 6 or 6.5. Let us talk about 6.5. It will be 45 plus the 120, the flap. So the total will be 165. 165. If you
Divided
divided by 550,
550.
I think you are 4 from 40. It's not. It's still.
Yeah,
It's
less
far,
than 40%.
It's still
Great.
you
Yeah.
are safe. So and here, if you think about, he has astigmatism 2.3 in the topography, and in the posterior, in the cornea back is 0.7. So it's 1.9. The astigmatism, it's reasonable with the. There is no discrepancy between the topographic astigmatism and the manifest astigmatism. It's within 0.9, and it's in the same direction. It's horizontal. So for this patient, I can go for LASIK. And still,
Great.
you can go for SMILE.
SMILE.
Both. LASIK and SMILE are okay for this, but I'm worried about the surface ablation because of the because he is diabetic, and the diabetic are prone to infection and healing.
Yeah, very nice discussion. Thank you, Dr. Majdi. Any other comments from the panel regarding?
Yeah, before going for my comment, I want to say welcome to Dr. Yasser. He joined us now.
شكرا جزيلا. Thank you very much.
You are so welcome, my friend. Okay, but I want to ask, Dr. Mazen, what's the problem with the diabetic patients? If we have normal fundus, there is no retinal insults from the diabetes. I have to be worried with diabetic patients about the epithelial healing, even if it's strictly controlled, and with the short duration of diabetes, or what's the rules in that?
Actually, whenever I face a patient who is diabetic, even if he is under control, fully under control, and the fundus is very clear, I'm worried about the instability of refraction.
Yes.
So I always tell the patient that even if we do the operation and it is 100% successful, you have to control your diabetes after the operation strictly forever. Otherwise, any change, there will be maybe what we call it regression, although it is not regression, it is because of changes in refraction because of the diabetes.
Yes.
And we have to tell the patient that any development of cataract in the future is not because of the treatment of the LASIK, it is because of your diabetes. Because sometimes they think that because they had the operation before, they developed the cataract.
So when you have a patient,
in addition, sorry, I'm sorry for interruption.
Okay.
The third point, I always tell the patient that you have to carry your information with you forever, because in the future, when you develop cataract, you will need this information, pre-op information for IOL calculations, for accurate IOL calculations, especially if the patient is in the pre-cataract age, just near the cataract age, late 40s, late 50s, like this.
Yeah.
Very good, Dr. Mazen. You summarized the problem with the diabetic patient, which is unstable refraction, liability for cataract, for early cataract, and the other problem of retinal changes. These are the main concern with the diabetic patient.
Okay, sir. Any other comments, or go?
Yes, please, Dr. Mazen. Actually, we have been speaking about the permafrost keratoconus a few minutes ago, and we have a hot spot here in the inferior part in the left eye. Also, let me tell you something. The refraction in the left eye doesn't go with the surface astigmatism. But, in other words, the -1 astigmatism in refraction is not coinciding with the 2.3 diopters of astigmatism, probably because of the hot spot.
Let me answer you, doctor. Yes.
Yes, just 1 second.
Yeah,
and I want to know from you something else. Is this a stable patient, stable refraction? Because if he's a stable refraction, okay, you can do whatever you want, and we have to carry on our diabetic precautions that you have just mentioned. Please, I want to know your opinion.
Okay, great. Now, of course, yes, the refraction is stable for this patient, especially when we are talking about diabetic patients. We have to be sure that their refraction is stable for at least 6 months, and whatever the age is. Okay. Now, regarding the astigmatism, actually, the 2.3 is for the anterior surface. Of course, the best way to study the astigmatism of the cornea is to look at the total corneal refractive power, which takes into consideration both surfaces, the thickness of the cornea, the real refractive index of the cornea. And very roughly, if we don't have that map, very roughly, we can deduct the posterior astigmatism from the anterior one. So the posterior is 0.7, the anterior 2.3. So the net is around 1.6. So 1.6 goes with the 1 diopter of manifest astigmatism. The difference is just 0.6, as Dr. Majdi mentioned before.
Do you want to do a higher order aberration map to the patient, this patient, or you don't worry about him when you are, if you go for refractive surgery? Do you like to do him a higher order aberration map?
Very good question. Yeah, very good point, doctor.
When you find the difference.
Yeah, exactly. Actually, studying the aberrometry, the corneal aberrometry of the patient, in my view, is mandatory for every patient. It's very, very important, because many cases we find very few irregularities. We may miss such irregularities, while the patient may have a coma, may have spherical aberration, and this may change the plan of treatment. Instead of going for the optimized, we may go for the, for example, wavefront guided or topography guided.
Yes, yeah. Yes. Dr. Yasser, do you want to say something? Dr. Yasser Rifay, welcome.
Yes, about this sagittal curvature map where there is this hotspot. I think this is not a real hotspot. Maybe there is a problem of dry eye or of lacrimal.
Oh.
Yes, I think it should be recaptured after cleaning the tears, or I think.
Yeah, very good point, Dr. Yasser.
Especially very good, that we see, very good, Mark.
Yeah, especially that we see this
Dr.
mark.
Mazen.
Yeah, this mark in the inferior part of the sagittal map, which may go with a tear meniscus, high tear meniscus. Okay, great. Okay. So now we can go to the.
Okay, there are questions from the audience about this case. Can I?
Yes, please.
Ask them, okay, to finish this problem, to make the message clear. What about the epithelial healing process in diabetic patients after surface ablation? They heard that from my professor, Dr. Magdi, and they asking again, is it practically reported if the diabetic patient with a restrictly controlled diabetes, there is a problem with epithelial healing, practically or clinically?
As far as I know, as long as the diabetes is under control, there will be no problem.
Okay, so we can see now that the diabetes mellitus is not a contraindication for the refractive surgery, provided that the all scales of the eye is normal, right? The second question, do you consider the HbA1c, the glycosylate hemoglobin?
Yes. Yes, Dr. Majdi, yes.
Just a comment. We have, as we said, sometimes there is a problem with the epithelial healing. That's why when you have two options, you have to choose the safest option. So we can, for this patient, the surface ablation, and still we can do LASIK. That's why we are choosing the safest.
Yeah, very good point, Doctor. Yeah, I consider the accumulative. Yeah, I consider it. I don't consider only the fasting or random.
Yeah, okay. Okay, thank you, sir. You can go for the second case.
Great, thank you very much.
You're welcome.
Case number 2. 45-year-old female. She came with stable refraction, no family history of keratoconus, eye exam within normal limit, including ocular surface, IOP, and dilated fundus exam. The mesopic pupil is 5 millimeter, both eyes. Now, the refraction is -3, -2 at 175 in the right eye, -3, -3 at 5 in the left eye. So the spherical equivalent, as you see, is around 4.5 in the right eye and, sorry, 4 in the right eye and 4.5 in the left eye. Now this is the for composite map in the right eye. Very quickly, the mean K is 45.1. The K max is 47.5. There is no inferior superior asymmetry, no skewed radial axis, very symmetric hourglass on the anterior and posterior elevation maps. The values corresponding to the thinnest location are within normal limits. The concentric, very normal pattern of the corneal thickness map. However, the thinnest location is 480, as you see. So we have almost thin, steep cornea. Okay, thin, steep cornea, but the K readings are still within the normal limits. Now we go to the left eye. The left eye has the same. KM is 45.1, no inferior superior asymmetry, no skewed radial axis. The elevation maps are normal. The thickness map is concentric. And for the pachymetry map, there is about 469 or 470. Okay, or around 470. So the
Can
first
you see the left eye? Yes, now. Thank you. Sorry.
Okay, now let's say that the first question, do you go for lens-based or laser-based? The question is for the panel. Do you go for, because the patient,
Professor Magdi, please.
For 45, she is 45, she has a steep cornea. So do we go for example, clear lens extraction with toric IOL or toric trifocal IOL, or do you still go for LASIK for this patient? Or PRK, let's say, or SMILE?
For LASIK, a patient with thinnest location for 170 or 80, I will not make a flap in a case like that.
Good.
Because I don't like to elevate, to make flap for a cornea less than 500. And we may think of surface ablation. First, we'll think for surface ablation. The K reading is okay, I think, because the spherical equivalent allow, it will be far from 34. But we have to calculate the total refraction with the mesopic pupil is 5, I think. So we can ablate for 6 millimeter. So the total refraction in the right eye is 5. 5, if you multiply by 13 for
so 65
optical zone 6 millimeter, it will be 65. So still
above 400.
Above 400. You can, but for the left eye, I think the total refraction is more. It's 6.
Yeah.
You may think for surface ablation in the right eye with full correction for the left eye, you can make like monovision to be the post-operative to be -1. But the other option of the lens-based is still okay, but I don't like to make lens-based for a refraction like this. If the refraction is -3, I'd like I don't like to go for intraocular surgery for a refraction like this. So still, I think I can think for surface ablation for the right eye with full correction, and for the left eye, I may leave the patient with -0.75 or something like that.
Very nice, yeah. Especially if the left eye is a non-dominant eye. Especially if the left eye is non-dominant.
What is the best correction of this patient, best corrected vision of this patient, Dr. Mazen?
2020.
The left eye.
Both 2020.
2020.
Yeah, with best corrected.
Best corrected 2020.
Yeah.
Even in the left eye.
Yeah.
Other option is the smile, but I'm not a big fan for smiles. That's why I don't discuss it. But I think surface ablation. This is my opinion.
I think I will do the same.
So Dr. Mahmoud, you are not with the smile for this case.
No. I don't. This is not a smile case. I do apply smile, Dr. Mazen, with the same parameters of LASIK. So this is under 500 microns. It's 470 something. And I think the patient, and you have raised a very important issue here, Dr. Mazen, and I would like to ask you a question about this. First of all, I agree with Dr. Magdi. I will do surface ablation in both eyes, and I will try to convince the patient to be undercorrected in the left eye. It will help in reading, and it will help to manage some near activity. But let us raise a very important question here, Dr. Mazen. This is a patient with steep anterior surface with normal posterior surface. Let us say on this, okay?
Yeah.
And the patient, I am astonished that the patient sees 20/20. Actually, I was expecting that to have it less than 20/20 in the left eye, especially because there is high astigmatism and steep cornea. Normally, steep corneas patients, they don't have the privilege of having 20/20 vision. Actually, but if we assume that this patient is not seeing 20/20 in her left eye, let us say in these kind of patients, they always end by best correction less than this. Do you think if surface ablation and correcting the high astigmatism can improve the best corrected visual acuity and the higher order aberration map of such kind of patients? Do you think of this?
Yeah, in general, correcting such high astigmatism, or even high sphere, will improve the perception at the level of the retina, because you know of the aberrations associated with such high errors. Even sometimes we may think that the patient has amblyopia with the best correct 0.8 maybe, and we are surprised after the operation that the unaided vision after full correction is 20/20. That's because the aberrations associated with such high refractive errors has gone.
Yes, I agree with you. Dr. Yasser, would you like to add something?
In this case, I will go for PRK. I will go for PRK for total refraction in one eye, but I will do the test. I will see the dominant eye and non-dominant eye to choose. I will not choose by the thickness, because the thickness, if we reduce the optical zone to 6 millimeters, we can do the all treatment, the treatment, complete treatment in both eyes. But we will see the patient, which is the non-dominant eye, to choose for near vision.
Dr. Hossam, do you like to ask some questions from the audience?
The same, sir, about the PRK. Okay, but I'd like to ask the same question of the participants or the audience about the customized ablation. Is it suitable in such case or not? About the thickness, if we are thinking in the customized ablation, I think we will choose the wavefront guided more than the topo guided.
Sure.
Yeah. So the thickness is allowing such procedure or not? This is my question, and from the audience too.
Okay, great. Now let me clarify something. Corneal wavefront treatment is actually topography guided treatment because it is based on elevation maps. This is a misconcept amongst many doctors. They think that corneal wavefront is a wavefront. The only real wavefront is the ocular wavefront, the total wavefront. So corneal wavefront means topography guided, but the difference is in corneal wavefront, we can select the high order aberrations that we would like to treat. And this gives a privilege of reducing the ablation depth. And sometimes you may be astonished. If we add some high order abrasions to the profile, you may find that the ablation depth is becoming less than the optimized, because some high order abrasions like trefoil are peripheral high order abrasions. So they will reduce the ablation depth in the center. So we cannot guess actually until we put all the information in the machine, in the device, and then we will calculate on the machine. If we are planning for wavefront or topography guided or ocular wavefront, the calculations will be on site, on the machine itself. We cannot apply the same monoline formula, which is, for example, 13 microns for 6 millimeter zone, or 15 microns for 6.5, or 17 for 7. Okay?
Yeah.
Any more questions, Dr. Hossam, from the audience?
Okay, but the general concept, the topography guided is at the corneal plane, while the wavefront guided, which is dependent on the ray tracing, will study the high order operations will throw the eye back to the retina.
One of the audience, Hossam, is asking, Dr. Hamdi is asking a very good question. This is a high astigmatic patient. Do you expect residual astigmatism? And if there is residual astigmatism, what will happen?
Okay,
this is
great.
Hamdi is asking this.
Very, very good question. Actually, before taking the questions from the audience, let me go into steps in the same case, because I'm going to highlight all issues. So the first issue that I'm going to highlight is the smile, because some colleagues may go for smile even in these cases, assuming that the laws of thickness of PRK applies for smile, not LASIK for smile. Okay, so the least amount of thickness is 470 to go for smile. For example, if the cornea is 480, they go for smile. All right. So in this regard, I'm going to highlight the smile technique. What is the smile technique? Because many audience, they do not know what's the smile, just to let them know how we choose the patient for smile. Now in smile, there is a refractive cut in the cornea, and there is side cuts in addition to entrance incision, followed by cap cut. In between, there is the lenticule that we extracted from the cornea. Above the lenticule, there is the cap, and below it, there is a bed. And this is the front view of the smile technique. Now we come to this concept in the smile. As we see, there is lenticule thickness. We have to choose the cap thickness to be sufficient for future enhancements, taking into consideration that the epithelium may be up to 80 microns. So the recommended cap thickness is at least 135 in order to leave sufficient amount for a new cut in the future, or at least 50 micron, 55 microns of stroma above the lenticule if we want to enhance by PRK. And regarding the lowest amount of bed is 270, and preferably should be 300 microns. Why is this? Because if we do 135 micron lenticule, then we have to know that there is 4 standard deviations of errors in the cuts, even in the femtosecond laser. So if we plan for 100 microns, maybe we are creating 82 microns, or maybe we are creating 118 microns. So plus minus 18 microns as a standard deviation in all cuts, even in femtosecond lasers. So when we say 135, because we want to avoid any interference with the previous cut if we future 100 micron LASIK cut, because even the 1 micron cut will have as well plus minus 18 microns of 4 standard deviations, as you see here. So I think the cornea here is not suitable for the smile technique if we are planning to go for such standard parameters. Of course, some surgeons may reduce the side cut Some surgeons may reduce the cap cut in order to gain more tissue, but I'm against. Any comments for the smile before I go to the cyclotorsion compensation regarding the residual refractive error? Any comment from the panel?
We go.
No. No, sir.
We
Okay,
go for
great.
Cyclotor, Dr. Mazen. Go ahead, please.
Okay. Now, as you see, the patient has high astigmatism, -2 in the right eye, -3 in the left eye. So for sure, we have to go for cyclotorsion compensation. I do cyclotorsion compensation in every patient having 1.5 astigmatism and above, in order to avoid any residual refractive error. Because as we know, the eye has like cyclotorsion when between the sitting position and the supine position under the machine. And if there is, for example, 10 degrees of angle of error, there will be at least 30% of the astigmatism remaining, but on a new astigmatism. We are creating iatrogenic astigmatism on a new axis, which is equal to 30% if the angle was 10 degrees. And in most cases, this astigmatism, the created astigmatism, is irregular, getting the patient into troubles. So this is the answer for the patient, for the doctor who asked this.
Yes.
Any comment until now?
Yes, actually, I will take the last point that you have added, and this is very crucial, Dr. Mazen. Thank you for writing this. And it's not inducing just a normal astigmatism, as you said, as you mentioned, it is a regular astigmatism. Actually, it's a secondary astigmatism, one of the higher order aberration, because you are creating a new pattern. Actually, and this is what will induce higher order aberration and the really unsatisfied. And very important what you have said about the cyclotorsion. And let me ask you now for the cyclotorsion, what is the maximum cyclotorsion angle that you have faced? We have our machines that can detect the cyclotorsions, and we sometimes we check it manually. And also about this, what is the highest angle that you have faced?
10 degrees.
10. I have seen 14 degrees. With 14 degrees, and it was amazing. You see the patient with one angle, and when it lies down, it has a very, very curious cyclotorsion. Actually,
Dr. Mazen,
Dr.
Mazen, there is one of the audience asking for to say again the cyclotorsion compensation, but in simpler way.
In simpler way. Okay. Now, as we know that the eye in the sitting position has a position.
Yes.
When we lie down on our backs, the eye will do a torsion. Okay.
Yeah.
Inwards or outwards. It depends. There is no rule for this. All right. Now, because the profile of the laser will go in a place, and we cannot rotate the profile of the laser. We cannot tell the machine, don't apply on 180, apply on 10 degrees instead, because we are entering the manifest refraction. If the astigmatism is at 180, so the profile will apply it at 180.
180 or
but
170?
Sorry?
180 to be 10 or to be 170 according, right?
Yeah, exactly. Now, the 180 for the manifest refraction is no longer 180 when we lie down on our backs in the supine position, all right?
Yes.
Why? Because of the torsion. So maybe the eye will take a position which is equal to 170. So the 180 profile will be applied at 170 or maybe at 10 instead. So there will be, first, no complete correction of the desired astigmatism. And at the same time, we are creating part of the correction on another axis which does not to be treated, which creates irregularity in the cornea.
Okay, but how to identify the direction of the cyclotorsion?
Can we just, because this is a very important issue, can we just explain to the audience how to overcome this problem?
Yes.
Most of the machines have the iris registration,
yes,
and it's solved automatically. but sometimes you have to do it manually. You
Yeah,
can,
exactly.
while the patient is in the sitting position on the slit lamp, you can make the slit beam horizontal and
Yes.
make mark at the 180. And then
Yes.
while the patient in the supine position, you check with the machine if it coincides with your marks or not. This
Yes.
just to
Very good. Thank you. Yeah, and if we don't if we don't want to do it on the slit lamp, of course there are two ways. The best one is the slit lamp because it is the simplest one. But there is another way. Another method is to use the marker for the toric lenses, which has a way or bubble, so that we can mark the 180 and let the patient go inside. Yeah, actually, I made a video regarding how to do compensation for the cyclotorsion on my channel on YouTube. Any other comments before I move to the other point in the same case?
Okay, from Jesus Alvarez. Dr. Mazen, do you use triple centration method on a smile, like Dr. Einstein?
Se llama Jesús Álvarez.
Okay.
Yeah. Yes, I do. And in addition, I do the cyclotorsion compensation as well by rotating the cone, like the way of Dr. Ganesh described. I rotate the cone in order to match the mark with the 180 of the cone.
Okay.
We
sir,
move.
Thank
I
you.
think, Dr. Mazen, you have a lot of things to.
Yeah,
Yes.
to finish.
Yes. Okay.
Yeah.
Sir, you can go for the next one.
Let's go for the next one.
Yes.
Now, regarding the PTA, some doctors are still using the residual stromal bed as the cutoff point for them, okay? But personally, I think the PTA is much better. Although some studies were published showing that the PTA has high sensitivity with low specificity, so we are going to exclude many patients who are suitable. But if we put in mind the 4 standard deviations of error in the cut, plus minus 18 microns, we cannot go for the residual stromal bed, because if we go for the residual stromal bed, which was recommended before 270, maybe we will not end up with 270 as a residual stromal bed. We may end up with 250. So it is better to go for the safer, which is the PTA. The PTA takes into consideration the 4 standard deviation of the cut. This is what I want to highlight in this regard. Do you agree, the panel? Dr. Yasser?
Yes, I agree. I prefer PTA.
Dr. Yasser Rifay wants to say something. Please, Dr. Yasser, تفضل.
So for I think the PTA is safer, and even when we can exclude some cases because of low sensitivity, we can do for them other techniques like PRK. But it's better than doing to cut or do LASIK for cases and go for 250 RSP. This is my I use PTA.
Okay, any questions, Dr. Hossam, from the audience?
I prefer PTA.
Dr. Magdi?
Thank you, Dr. Magdi. Yes.
The same.
Yes, I would prefer PTA.
Yeah, good.
Yeah, the same from 2014, the PTA is highlighted by Marconi, but it's more safer and more convenient to put the patients on the PTA. But the last time, while we were talking with Renato about the residual stromal bed and the PTA, he conducted a study about the difference or the comparison between both terms in regard of TG. He said that the PTA, even 40% or less, but with a residual stromal bed less than the accepted one, they developed ectasia. And so one of the recommendations of this study to consider both together, the PTA and residual stromal bed as well. And I agree with that.
Yeah, but for the residual stromal bed that Renato
300.
recommends, 300.
Yes.
Yeah, actually, if you follow the PTA, it's always above 300. You will find it above. If you follow it strictly, you will find the residual stromal bed is above 300.
But in the borderline cases, with high error,
maybe,
you
yes.
may exceed, yes.
Yeah, maybe, yes.
Yeah, okay.
Yeah, and thin corneas. I agree.
Yeah, okay, sir. From the audience, no, there is no questions for this point.
Okay.
Okay, so we highlighted
carry on.
Yeah, carry on. Okay. Now, my question to the panel: what is the least thickness after PRK you allow? For example, if the cornea was 500 before the operation, do you leave safety margin 400 microns, including the epithelium, or you may go beyond?
Do you mean less than 400, Dr. Mazen?
Yes.
Yeah. After the operation, what is the least thickness do you leave?
I never leave less than 400. Actually, more than 400, Dr. Mazen. I don't know what's the other audience. Do you like to add, Dr. Yasser, something?
400. 400.
Dr. Majdi?
For me, 400 is
Yeah.
400 is the
And
least.
you yourself, Dr. Mazen, what do you prefer?
Yeah, for sure. It should be 400
For sure.
at least. Above 400, yeah, exactly, including the epithelium. Now, what are the limits of the K readings? Let's say if we are treating myopia, high myopia, the post-op K reading should be more than what? 34?
For me, the least is 34.
32. Dr. Majdi, 32?
No, 34.
34, Dr. Magdi, 34.
Okay. So yeah, 34 for all of us.
On the other hand, on the other side, for the hyperopic correction, 48.
48, yeah.
Yes.
Okay, can I ask a question?
Yes, please.
Okay, let me ask the question in another way. How many degrees of myopia you will correct with the PRK? Whether the ablation depth is allowed and acceptable for you to do with PRK? 70 microns, 80, 90, less, more?
Yeah, great. Now, the highest degree that I treat by PRK is -8 spherical equivalent.
Yes.
Okay?
Yeah.
In addition, it should not end up with a cornea less than 400 microns. So as long as the thickness allows me to end up with more than 400 microns, I treat. But I do not exceed -8 spherical equivalent. I don't treat, for example, -10. Even if the cornea is 600, I don't treat -10.
Okay, but what about the epithelial thickness? Yeah, 400 including the epithelium, right?
Yes. Yeah.
Then we should to know the epithelial thickness to measure it.
Yeah, exactly.
Yes.
This is the importance of the epithelial mapping nowadays.
Yeah. Okay.
Dr. Yasser will tell us about it.
Yes.
Okay. What about the haze? Finally.
This is the importance of Dr. Yasser Rifay nowadays.
Yeah, okay.
Okay. Regarding the haze, actually, up to my knowledge, the old thoughts that with more than 80 microns you will end up with too much haze. Yes, actually too much haze, but before the era of Mitomycin-C.
Yes.
That was before the Mitomycin-C.
Yeah, okay.
And also, Dr. Yasser, Dr. Mazen, sorry, with the old era of the flying spots and the multi-fly spots and the broad beam was horrible. I remember, Dr. Mazen, when I started in 1992, we used to keep the patients on months with steroids, large months with steroids for fear of the haze, because we didn't use mitomycin at that time, and at least 25% of patients, they had some kind of significant haze, and we had to do a lot of redo because of haze, not because of undercorrection. Of course, at that time the patient was different. If you remember, Dr. Mazen, what have changed يعني in the last 30 years or 25 years actually. It's not only the techniques, not only the lasers, not only the machines, not only the diagnostic, but the patient have changed. The demand have changed. If you remember at the early 90s, when I started PRK in 1992, I was fellow at that time in Spain. The patient was very satisfied with decreasing the myopia, Dr. Mazen. Nowadays, they come and judge you for minus half a diopter.
The lifestyle
Sorry
has
for the
changed.
word, yeah.
Yeah, the lifestyle has changed. Exactly.
From the audience, sir, the use of the Mitomycin-C is for the old cases of PRK or for the high errors. Up to myself, for all my cases. What about you, sir?
All my cases.
Yeah, even the mild degrees of myopia. Dr. Magdi?
Yeah.
For me, all cases, and since I started using mitomycin, I never see haze, and I had a case of minus 1.25, and she developed haze because I didn't apply mitomycin. That's why for all cases I apply mitomycin.
As a primary.
Dr. Yasser, do you like to say something? Dr. Yasser, do you want to say something?
Yes, I use mitomycin when I find it, because in Morocco sometimes we do not find it. When I have mitomycin, I use it for all cases. But sometimes we do not have it.
I may send for you, Dr. Yasser. Mitomycin-C. Okay. But Dr. Magdi, I think you agree with me about the PRK as primary case, the haze in primary PRK. But about the PRK in redo ablation or enhancement, the mitomycin will not achieve the same job, right?
Of course, patient surface ablation for enhancement is a big problem, because you see, you will remove the epithelium, the patient will feel pain again, and this is a big problem for the patient. And again, you may have haze in spite of using mitomycin. But in case of redo for PRK, you have to keep in mind to use large optical zone, apply mitomycin, give the patient some vitamin C, and keep patient on steroid for a longer time.
Okay, sir. Dr. Mazen, we are talking about the redo on top of a flap, PRK on top of flap. What about your experience in that?
Yeah, of course, I have to triple the time of mitomycin when I apply PRK over the flap.
From 20 seconds to 60?
Yeah, sometimes, yes. Up to 60 seconds, yes. Of course, not too much I do the PRK over the flap, because I have to check the thickness of the flap, and the stroma of the flap is sufficient to take off the refractive error without ending up to the interface. I don't want to ablate the whole flap at the end.
Okay, you have to measure it with the OCT first.
Yeah, and usually trans-PRK is the best option.
Yes. Trans-PRK, but after assuring about the flap thickness itself.
Yes, exactly.
This is very important point, to not to remove the epithelium manually over a flap.
Yeah,
it's better to do trans-PRK.
Yes, exactly.
Yes, sir.
One of the audience here, Dr. Hossam, is asking about when to start the steroids in PRK.
Yeah.
I usually personally wait until the epithelialization, more or less 2.5 or 3 days. What do you do, Dr. Mazen and Dr. Magdi and Dr. Yasser?
I start immediately, actually.
You are not afraid of delayed healing?
No, because...
You never faced the case of delayed healing?
No, at all. Because scientifically, let's say that Harminder Dua published a very old study regarding the effect of steroids on the epithelial healing migration, replication, and so on. The steroids does not affect. And in some cases, as you know as well, sometimes of delayed healing, if we add steroids, it will beat the inflammation that prevents healing. So I'm not talking about the PRK. I'm talking sometimes you have, for example, corneal abrasion with delayed healing. It stops at one point. If you don't add, for example, fluorometolone, there will be no progression in the healing. So regarding the delayed healing that I face from time to time is not related to steroid, because in all my cases, I start with the steroids from hour 0, not from second day, from hour 0.
Yes. Dr.
And
Magdi?
Dr. Yasser.
I use steroids from the first day, and I add 2 days. I use 2 days of non-steroids. 2 days, the 2 first days non-steroid plus steroid, loteprednol, and the non-steroid gives the patient have no pain. In the first post-operative day, no pain, white eye. It revolutioned my practice of PRP.
Yes, I agree.
And of course, we all agree about fluorometholone.
Or loteprednol. Loteprednol. Lotemax.
Lotemax. Okay. Dr. Magdi Bey, you wanted to say something?
Yeah, I usually waited for 3 days and then start steroid.
I'm afraid we have to disagree, because we have, you know, Dr. Mazen, from place to place in the whole world, things might change.
Yeah.
Hot, humid, with low hygiene patients is a disaster.
Yeah.
But
for instance, in Florida, in the United States, because of the hot, humid, and the prevalence of fungi, a lot of fungus infection, they are prohibited to give steroid the first day, because they have a higher incidence of fungal infection, fungal keratitis. Here in Egypt, if you are treating special patients of a special sector of patients, and you know what you are dealing with, there is no problem of giving steroids. And I insist on fluorometholone, and I'm really I did a lot of work on it. But if you are treating a Dr. Mazen, a low hygiene patient, coming from a hot, humid, dusty area, things might change your mind.
I agree with you actually, but as you said, it depends from country to country, area to area, in the same country. Because even in the same country. Yeah, I agree with you.
Yes.
May I
And
say
do you
something?
put a contact lens, Dr. Mazen? Dr.
Yeah,
Hossam,
of course. For the surface ablation, I do, yeah.
Yes. Dr. Hossam, I'm sorry I interrupted you.
No, sir. But please forgive me to disagree. I agree with Dr. Mazen. I'm giving steroids from the hour 0, frequently from the first day, and with no negative feedback about that. The prednisolone for 2 weeks, and then I shift to the
Basha.
Yes, sir.
Please, Dr. Hossam, I will say it in Arabic. I'm sorry, I have to say it in Arabic.
Yeah.
لما هيجي لك خراج في القرنية حالة واحدة هتتوب فيها، هتتوب إلى الله. يعني حالة واحدة فانجل كيراتيتس بعد PRK تتوب إلى الله فيها.
ربنا يستر.
Let us continue. Dr. Mazen has a lot of things to say to us. Please, Dr. Mazen, sorry for interruption.
Okay, the last question, Dr. Mazen, for our chairman. Do you use, instead of the steroid, the non-steroidal for the first days?
No, lubricants, antibiotics, contact lens, and I have to see the patient personally after 48 hours. PRK it's a very easy surgery, but at the same time the patient can go wrong.
Yes.
Jesus Alvarez from Mexico is saying, I use steroids first day, and I have a lot of mitotic keratitis also, but he has, in his words, he wants to say that he's very careful also, but he gives steroids. So, Dr. Mazen, can we carry on, because I'm sure that you have a lot of things to tell us.
Dr.
Yeah,
Mahmoud,
inshallah.
Dr. Mazen, I'm so sorry.
Yeah, تفضل.
Professor Dr. Abdulmanam Hamid, Professor of Ophthalmology, Banha University, saying to you, Assalamu alaikum, would you ask you why you did analyze this case with BS3, the last case?
Why I did what? Sorry, what was the question?
Why you did analyze this case with BS3? He means
Why
the last case.
yeah. Why I analyzed it with PS3?
Yeah.
It is not only this case. I always analyze my cases, all cases with the PS3. I follow the PS3 very strictly.
Yes.
Okay.
What's the PS3?
What the PS3?
What is the PS3? It is a practical subjective scoring system. It is something that I created based on evidence-based for each item, okay? And then I gathered them in a table to classify them into moderate risks and high risks. Of course, these are my observations. We have to test this against people having ectasia, of course. And actually, we are carrying a study to test this PS3, but personally, I apply it strictly. And by the way, people may think that if we apply this, we may exclude many patients. That's not true. If we know how to read the topography, if we know how to exclude factors of false positives and false negatives, then we will end up including most of the patients safely in this PS3. Okay, so let me move to the point of if we are planning to go for example, for this patient for lens-based, okay? Yes. For example, clear lens extraction with toric IOL. Of course, I don't do clear lens extraction for myopic people, but just in case, this is why I presented the specular microscopy, because this is one of the main investigations that we have to do before any intraocular study, surgery, I mean, intraocular surgery, even in cataract. We have to do the specular microscopy even if we are doing cataract. So usually in the specular microscopy, we look for three parameters. The first one is the hexagonality. The second one is the cell density. The third one is the CV index or polymygetism. The hexagonality should be at least 60%. The cell density should be at least, based on the age, of course, 2000 to 2500. And for the CV index should be less than 40% to say that this case is suitable for intraocular refractive surgery. So I'm going to ask the audience, not the panelist. Do you really do specular microscopy for every patient you are doing phakic IOL implantation or clear lens extraction? No need to answer me, but just keep this question in mind. Now, as you see here, this patient has the hexagonality is borderline, it's 58. The cell density is more than 2000, which is good. The CV index is less than 40%. This is the left eye. The hexagonality is less than 60%, which is not good, although the cell density is more than 2000 and the CV is less than 40%. Any comment or question regarding this point?
No, I agree with you, Dr. Mazen. It's very important to do the specular microscopy, and I agree with these parameters. The hexagonality must be more than 60%, and the CV must be less than 40%. It's okay.
I have a question. Shouldn't we do the specular microscopy for all refractive surgery? I mean, laser-based surgery. can we operate guttata with LASIK or with PRK? This is my question.
Yeah, very good question, doctor.
Very good question.
Yeah, whenever I see more than 600 microns cornea, I have to doubt. Whenever I see any abnormal appearance of the cornea on the slit lamp, and whenever I see a flat thickness profile on the spatial thickness profile, whenever it is flat or almost flat, I have to think about cornea guttata or Fuchs dystrophy. So these three things. And whenever I find it, yes, there is Fuchs or guttata, I don't do laser-based, I don't do lens-based.
Thank you.
It's not a refractive surgery patient at all.
Yeah, exactly.
Yeah, okay, but we will go for the specular microscopy in the old cases, even in the young patients, just for determination of the hexagonality and the density, or also for the follow-up of the patient.
Good point. Yes. If we are doing phakic IOL, yes, for follow-up.
To know if there is an impact on the corneal endothelium after a time with the phakic IOL, and what's the time expected to find the changes after the surgery? That these changes are permanent, not transient one.
Mm-hmm.
What time to pass after that? Did you get my point?
Yeah, when to say that now we have to remove the phakic IOL, you mean?
Yeah, the time. If you put a phakic IOL, you may expect that there are some changes in the first weeks after surgery.
Yes.
Yeah. Okay.
Loss of endothelial cells.
Yeah, but after time, it may be compensated. It may pass well. If the changes is still or progressing for a time, so I have to ask for specular microscopy in which intervals after surgery, after 1 month, after 3 months, and so. And when to decide to extract it is a difficult decision, but I have to do it at the suitable time before losing the cornea. So, what the changes to help me to take this decision?
Very nice point. I don't know actually. If you can tell us, please.
Okay.
I think any intraocular surgery will impact the endothelium.
Yes.
So if you ask for specular microscopy, say after 1 or 2 months, then the loss of endothelium at that time is mostly related to the surgery itself. And then, say if you ask for specular microscopy after 1 year or something, and you see if there is a significant loss or not, because there is a normal regular loss every year, which is I think 0.6% loss of endothelium regularly, even without surgery.
Yeah.
If the loss of endothelium every year is more than this, or you see any sign of decompensation or something like that, you have to deal with the case. But I think in most of the chamber phakic IOL, there is no significant effect on endothelium.
What I know that the phakic IOL makes a loss of 2%, so it increases 3-folds of the age-related loss. As Dr. Majdi said, that 0.6 per year, 0.6% per year, without phakic IOL. But with phakic IOL, as far as I know, it comes to 2%.
2% changes.
I think it's more for Mazen.
Loss.
I think it's more than 2%. I think it goes up to 5% if it's a phakic IOL, especially the iris glow, because of the subclinical uveitis or subclinical inflammation that happens, and this triggers the endothelial lifespan. Also, the circulation of the aqueous circulation changes when the phakic IOL, especially the iris glow, and you have you have triggered here a very good case here, Dr. Mazen, about the endothelium, because this is a very tricky case. You have a high density or relatively high good density, but the coefficient and the hexagonality are not very good. So one should be careful when he looks to the measurements of the endothelium. And this is very good that you have raised this issue actually. If you are a very excellent phaco man, if you are an excellent phacosurgeon, when you enter the anterior chamber, you will lose 500 cells density. And then the coefficient, which is borderline, or the hexagonality borderline, it will drop to 50%. So that's why if you look at the beginning, before entering the anterior chamber, for the coefficient and for the hexagonality means the susceptibility of the endothelial cells to break through, to unloose the attachment. So the coefficient and the hexagonality, the liability of the cells to change its shape, this is very important, and I really really appreciate that you have put this tricky parameters to let us be careful before entering the anterior chamber with this kind of parameters.
Yeah,
please.
Yeah. We have to calculate that before going to the intraocular surgery. Yeah. To be well.
If you are an excellent phaco surgeon, by just entering the anterior chamber, you will lose 500 cell density, and this is the other parameters will drop dramatically.
Yeah, this is a question which we discussed before, Dr. Mahmoud, about the surgeon who went for phakic IL for just -2 diopter in patient with thin cornea.
Tell Dr. Mazen about.
If you have such a case, Dr. Mazen, what would you do? A patient with thin cornea, all the parameters are okay, but the cornea is thin, 455 micron thin location, with -2 diopters. So he is not candidate for the PRK even. But my colleague advised, asking me about that, and my professor, Dr. Mahmoud, we advised this doctor or this ophthalmologist to advise this patient to be on the glasses or the contact lens. But he went for another one who went for PKKL for just -2 diopters. What's your evaluation for this act?
I always tell my colleagues that the phakic IOL is a foreign body. I don't open the eye to put a foreign body for less than -5 diopters.
Yes.
I don't put foreign body inside the eye. So I'm doing two problems: opening the eye and putting a foreign body. So there must be something worth to do this.
Strong reason to do it.
Strong reason.
Yes.
Dr. Yasser, what is the minimum refraction that you go for ICL?
Normally it's -5, -6. I've done once -3, one case.
-3.
-3. Yeah. Case. But I try to convince the patient to avoid, because there's a lot of risk, and they give him a paper to sign before.
Dr. Magdi, the least is -5, also -6, as Dr. Mazen said, or you go less than -5?
And mostly not less than 4. Not less than 4.
Yes, okay. Yes, sir. We are.
Okay, Dr. Hossam.
Yes.
Dr. Hossam, I'm still waiting for the answer of your question. Your question was very, very clever. When to do specular microscopy and to decide to extract the phakic IOL. I need the answer from you.
Actually, I asked the question, which I don't have the answer for it, but logically, we will put a rule. we will put a rule. If I have found that my patient is losing which is more than expected loss of the endothelium within within first 2 or 3 years, depending upon the original cell density and hexagonality. If they are progressing badly, I will remove the phakic IL before losing the cornea. Let's put it on this case. If the hexagonality in this patient is 51% and the cell density is 3,380s, on the second year or after 1 year or 6 months from the surgery, I found that the cell density is down to 2,000 and hexagonality is much less than this figure, I will take the decision to save the cornea and remove the phakic IL, according to every case. Yeah, we can put it as an individual parameter. This my perspective.
Great.
May I ask Dr. Mazen, Dr. Yasser, did you ever remove ICL for a problem in the specular microscopy, or I mean in the endothelium? For me, I'm implanting ICL long time, and still I didn't remove a single case for this reason. There is no problem with the endothelium, or no significant effect on the endothelium. But actually, I removed, say, anterior chamber lenses, iris glue. Yes, it happens that I got some cases got decompensation because of the iris glue or the anterior chamber lenses. But for the ICL, till now, I didn't have a single case. Can I hear your comment?
Yeah, Dr. Yasser.
I never removed for this indication. For me, never have any loss of cells, even of my cases or my colleagues' cases.
Yeah, actually, I saw only maybe one case, yes, of one of the colleagues that the cornea went into decompensation, but I don't know why the decompensation was there. Maybe because the pre-op and specular microscopy wasn't studied very well. Maybe the eye wasn't fit for that. So I saw only one case for that. But of course, I didn't extract it. I sent the patient to his doctor to do the job.
Okay, sir. To complete the answer, I have extracted just one of my cases, which at this case, I have used the iris claw. Nowadays, we are putting ICL, but the old cases with iris claw, the anterior chamber depth was borderline 2.9 millimeter in this case. So I was following this patient 6 monthly with a specular microscopy. And when I found that there is a down progression or loss of the endothelial count and the increase and also the hexagonality was changing, so I took the decision to remove just one eye. The second eye was well, so I didn't do.
Okay.
Okay.
Great.
I noticed that there are some doctors. Maybe when we have for ICL, maybe we can have the compensation when we have this case when doctors have an upside down ICL and they try to return it in the eye. Sometimes they lost a lot of endothelial cells during the surgery. Then the patient will have the corneal edema. And I think that after this kind of surgery, the patient will lose a lot of endothelial cells, and they might have they can have the compensation very fast after. When you have an upside down, I had it once. Do you return the ICL inside the eye, or do you take it out and reinsert in a second time?
You did that. You extracted it and then re-implanted it.
Yes.
Okay.
Actually, I would prefer to get the lens out and reload the lens and re-inject again.
Yes.
Yeah. Okay. Actually, I got it just once, and they find it with the OCT anterior segment, and I inverted it inside the anterior chamber, but fortunately, it's well until now. But I know that it's risky, it's dangerous movement. Okay. Okay, sir, I think this point is fully clarified now. We can go for another one.
Yeah. Now, let's say that we are going to implant for the patient lens-based, okay?
Yes.
Of course, one of the main investigations that we have to study is the wavefront, corneal wavefront. Even if we are planning for phakic IOLs, or we are planning for clear lens extraction and premium lens implantation. What we usually do, we study the wavefront of the cornea altogether. Of course, we have to be sure that it is the 6 millimeter zone, maximum diameter.
Yes.
And wave aberration of the cornea. We usually click on row N3, which is the vertical trefoil, vertical comma, horizontal comma, and horizontal trefoil, and the spherical aberration, which is in the N4, M0, N4. So these 5 should be studied, and the RMS here will be this one. The RMS of the high order aberrations will be displayed here in total, and here for the spherical aberration. So by this, we can say that the premium IOL can be implanted or not. Usually, if the RMS of the high order aberrations is more than 0.35 microns, which equals 0.5 diopters, if it is more than this, usually premium IOLs cannot be implanted. So this is what I want to highlight here. This is for the left eye as well. It is here 0.411. So any comment from the panel or regarding this point?
No, I agree with you. If the comma and trefoil exceeding 0.5, the quality of vision will be bad after premium.
Yeah. Any questions from the audience, Dr. Hossam?
Not from the audience. Okay. Up till now, there is no question for this point. But about the high order operations in such cases, on such procedures, can we correct if there is a residual error or high order operations after implantation of the phakic IOLs? Can I correct it with the customized ablation on the corneal plane?
Yes, of course, you can by corneal wavefront.
Yeah.
But you have to tell the patient that this is not guaranteed. If the dysphotopsia that the patient suffers from, if it continues to occur after the treatment by the corneal wavefront, then extraction of the premium IOL. Hello?
Yeah, yes, sir.
Yes.
The internet was unstable for the last.
Yeah. So, did you hear my last comment?
And not the last half of it.
Can you repeat it, Dr. Mazen,
Yeah,
just in case?
repeat it, please.
Yeah.
Last half of it here.
Okay. Now, of course, we have to exclude all patients having high order aberrations from premium IOL implantation. But let's assume that it occurs. Okay, a patient comes after the operation. We discovered that we did not pay attention to the high order aberrations that he had before. And the source of the high order aberrations are the cornea. So in this case, we can study the cornea for the treatment by customized laser vision correction. But we will tell the patient that if we treat and then the dysphotopsia didn't go, then the second step will be excluding the premium IOL.
Yes. Okay.
Yes.
This is.
We go here for a very important question, Dr. Hossam, if you allow me, please.
Yeah. Okay, sir.
We have a patient that is not satisfied with the premium IOL being multifocal or just a premium IOL or a toric IOL. how long you will wait for the neuroadaptation to happen, Dr. Mazen? Because we have squeezed Professor Alio a few 2 weeks ago about this point, and this is very crucial to understand by our average specialist. I would like to know the opinion of the audience about how long you will wait until you are fed up with the neuroadaptation and no neuroadaptation is happening and you have to take action. How many months do you wait?
Okay, theoretically, what is written in textbooks or being said in conferences is 6 months. But I think 3 months. After 3 months, if you find that the patient has no improvement, even no small improvement, I think he will not improve anymore. After 3 months.
Yes, Dr. Mag, did you have another opinion, and Dr. Yasser also?
No. Same.
Same.
Actually, I would like to tell you something, Dr. Mazen.
Yes, please.
6 months, yes. I have waited more than 6 months, actually, with a couple of patients. I am not a fan of multifocal IOLs. I seldom do them. But I have faced problems from other colleagues, especially people they are not taking care of the corneal mapping or the pupil and mesopic pupil especially. And these kind of patients, they usually give you a headache following the research. The worst one is the patient who has negative dysphotopsia. This is the worst one of them because he has higher order aberration. There is new neuroadaptation, and also he's complaining of seeing the edge of the pupil, or the edge of the IOL, I'm sorry, and the rings of the multifocal if you have implanted multifocal. If he waits with you, and if you can wait for him more than 6 months, actually, as you have said, few of them, they improve. But now we come to the 3 months that you have said. What is the benefit of waiting only 3 months? Actually, it's an easier surgery because the more time you wait, the more difficult to extract an IOL, and this is the logic of it. The 3 months. Actually, I have now remodified my way of thinking, not because of there will be or not will be a neuroadaptation, because the surgery after 1 year is completely different from a surgery after 3 months.
Yeah.
After 3 months, you can guarantee that you can take an IOL and put another one in the bag. But after one year, are you sure that you can do the same surgery? It might not succeed as you want to.
Yeah.
So we have to be careful, as you said, mapping, electing the patient for multifocality.
Yeah.
Okay, sir, to take the edge of this speech, I think the patient for premium IOL should be premium patient. Yeah. When I asked Professor Alio about that, about the high order operations in the presbyopic IOLs and the residual astigmatism after that, he said, Dr. Mahmoud, remember that, he said, you have to exclude, you have to cancel this patient from the premium or the presbyopic IOL because he will not be happy and will get you a lot of headaches after surgery. There's a question
you mean the one with the high astigmatism?
The high astigmatism or the high order aberrations, which
of course, high order aberrations, yeah.
Also about the pupil size. I asked him about the pupil size should be the
2 to 6
optimal, 4 to 4.6. So there's a question from Alvarez, Dr. Alvarez, he said in the post laser vision correction, check specifically on spherical aberration because of a spherical IOL negative or neutral. I think it's not a question. It is
actually it's not a question.
But
there is a question from Miguel. He's
Miguel,
asking about, do you recommend the measurements of higher order aberration at 4 millimeter pupil zone or at 6 millimeter optical zone?
He means, I think the one who is asking means ocular wavefront. Because ocular wavefront
Yes.
is affected by pupil, but the corneal wavefront is not.
It's not, because the corneal wavefront map is a fixed map, but the pupil, the ocular higher order variation map, Don Miguel, is pupil dependent.
Yeah, exactly.
Question from Dr. Abdelmonem Hamid. What
Yes.
to do if you don't have a pentacam and you have only an oculizer to get, what to do to get RMS or high order aberration?
Yeah, there is in the oculizer, there is Zernica analysis. It is the same.
Yes.
Present? Yeah, it's available in the oculizer.
Yes.
Yeah, okay. Okay, sir, high order aberration are very important, the same. Yeah, okay, there's no more questions about this point.
Yep.
Yes.
So we can move to case number 3.
Please.
Okay, but there is a question here finally about the angle kappa. Yani, you talked about the high order aberrations in the premium area. What about the angle kappa? And I want to cover both in the laser based.
Case number 3.
Yeah, case number 3. Okay.
About angle kappa.
Yeah.
Okay, great. Now, this patient is a 39-year-old male, stable refraction, no family history of keratoconus, eye exam with a normal limit, including ocular surface IOP and dilated fundus exam. Mesopic pupil is 5.7 millimeters, both eyes. So 39. +6 in the right eye, minus 0.75, 160. Best correct visual acuity is 0.4. The left eye is +3, minus 0.5, 180, and the best correct visual acuity is 1 decimal. So as we see, there is anisometropia and there is amblyopia. Okay?
Yes.
And it is hypermetropic case. Now we come to the pentacam of this patient. We see that the patient has the average K is 42.3. There is no inferior superior difference. There is no skewed radial axis. The anterior and posterior elevation maps are within normal limits. We can say that there is a kind of horizontal displacement of the thickness map, as you see.
Apex.
Yeah, the whole pattern is displaced horizontally, and that's because of high angle kappa. If you look at the pupil center coordinate, you will find that the X is the 0.68. Usually angle kappa is best studied by Placido-based, but since the pentacam doesn't have, there is the holiday report, which has the chord mu. Chord mu is quite similar to the angle kappa. And if you have the old version of the software of the pentacam, you will not find the chord mu in holiday report. So in this case, you have to depend on the pupil center coordinates. You just divide X and divide Y of the pupil center coordinates, and it will be roughly, of course, the angle kappa. So in this case, angle kappa is around 340 microns. 340 microns. The X is 340 microns, which is borderline. Now we come to the left eye, the same. The KM is 41.7, normal corneal topography, horizontal displacement, which is consistent with the angle kappa. So as you see, the angle kappa here is almost the same. We can say that it is the 350, almost 350 microns. So we are facing here a case of hypermetropia, anisometropia, amblyopia, and large angle kappa. Now, what is the first thing to come to mind in this case? Because, you know, KM is similar in both eyes, but the refractive error is not similar. There is an isometropia. So we have to think about axial hypermetropia, making this an isometropia, because as you see, the topography cannot explain this anisometropia. Both eyes are similar. So based on the corneal topography, both eyes should have same refractive error. But because of the big difference, then there must be a difference in the axial length. This is the first point. Now, how do you treat this patient? This is the first question. Laser-based or lens-based?
Lens-based is excluded.
It is 39 years, Dr. Magid, Dr. Mazen.
No, yes. But +6 and +3.
Can we
And
go to the
Hyperopia and amblyopia. Yes, Dr. Majdi.
Can we go to the right eye to see the topography of the right eye again, please?
I wonder if I can go backward and zoom. Ah, yes, good.
Okay. It's this is the one with the high refraction, huh?
Yes.
I think the intraocular lens is not possible, the phakic IOL, because the anterior chamber depth is very small.
2.2. Yeah, very shallow. Yeah.
And on the other hand, if you think of for laser-based, if you get the spherical equivalent of 6 and you multiply by 1.2, it will add 7 or 7.2 to the 43, the Kmax.
Yeah. Yeah.
So it will exceed 50.
Yes.
For the lens base is not recommended, this one. So sorry, for the laser based is not recommended. This for the right eye, because the K reading
will exceed.
Will become hyperpolyrate and will have aberrations. So I think we may think for lens based. On the other hand, the thinnest location is 488. I think we can better go for lens-based.
Okay, lens-based, you mean clear lens extraction with premium IOL?
Yes.
Not phakic IOL, because the anterior chamber depth is
IOL, low. The anterior chamber depth is
very low, 2.2 in the right eye.
It's
2.14.
The phakic IOL not commonly used in hyperopes, mostly in myopsy, because of the anterior chamber depth. So for the right eye, I would think lens-based with premium IOL. The angle kappa is very important in this aspect, because you have to implant your lens at the visual axis, not at the center of the pupil. You check, so the angle kappa is very important here. For the other eye,
angle kappa is borderline, because usually implanting premium IOLs are contraindicated when angle kappa is more than 400 microns. Here it is.
It's borderline.
350.
Yes.
So the patient may have dysphotopsia, correct?
Yeah, may have.
Yeah.
I think
so
most of the premium IOLs patient may have dysphotopsia for it differs from a type of lens to another, but some degree of dysphotopsia, I think, usually happens. I think for the other eye, also for the right eye, there is a skewing of the axis, but I think the astigmatism is very little. Huh? The right eye, there is skewing of the axis here. If you
less than 22, actually, it is less than 22.
Yeah. Okay, but the astigmatism also, the total astigmatism is
almost 1.
Yeah, almost 1. It's acceptable.
Yeah.
You can neglect this skewing. It's okay.
Sorry for the skewed. When we have a very large angle kappa, we always have a small skew.
Yeah. This is
a very good point, Yasser.
Yes.
Yes, Dr. Yasser, is the skewing is because of mostly because of the angle kappa.
So
I would like to ask Dr. Mazen, if this patient.
Yeah, tell me, doctor.
Sorry.
Again,
if this patient has a normal cover test, by other means, there is no angle of squint, just a wide angle of kappa.
Just wide angle kappa. No,
No, normal cover test.
yeah, no phoria. No, let's say no phoria. Yeah. Or no significant phoria. Of course, phoria is in everybody, but no significant one. Yeah.
Okay, Hossam, go ahead.
Okay,
Okay.
just to take general points from this case for the audience, when to expect a large angle kappa, not skewing. In your review, you ask it, the examiner or the interpreter, to check the angle kappa before going before interpretation of the skewing, and also the misalignment. This image could be in the pentacam with the misalignment with a large angle kappa to exclude the significant skewing in the topography of the patient. Right.
Yeah.
The second point, simply why not for the laser vision correction before of the thickness, because of the thickness, or other factors?
Because of the thickness and because of the
you have three issues here.
Yeah.
The post-operative
K reading, post-operative.
K reading, post-operative, the thickness also.
K reading, the steepest K is 43. So if we correct +6, it will up to?
You will correct 6.
Yeah.
This, so you will multiply by 1.2. This is hyperopia. So it will be 7.2. The K max is 43 point something with 7. So you will exceed 50. I don't like to exceed 48, but this is more than 50.
Okay, I consider the K mean or the K max in such cases.
In such cases, you consider the K max because this is hyperope. If myope, you consider the flat K.
But it may depend on the point or the position of the K max. It's shifted up. It may be related to a steep point in the superior cornea.
It's not shifted up. It's
in plus. It's with plus sign. It shifted horizontally. It's not vertically. So it's away from the thinnest location. It may be a hot point or dry spot on the cornea. So my question for the general rules, I consider the K max in such case, even if it's away from the thinnest location in cases for hyperopic correction, or to take with the K mean or the steepest K.
Okay, now
for all of you,
yeah, let me answer this question. Actually, I consider the spherical equivalent, okay?
Yes.
And apply the spherical equivalent on K mean, the Km.
Yes.
Now, if the difference between K max and Km more than 1 diopter, we have to consider Km. We have to consider K max. Why? Because this big difference may create irregularities on the cornea.
Excuse me again, this point again, please.
Yeah. Now, usually the spherical equivalent is applied on the Km, and the Km should be no more than, not less than 34. The post-op Km should not be less than 34. And for me, I do not exceed 49. Up to 49, it's acceptable for me. 48, no problem for other colleagues. Now, if we are applying hypermetropia, we have to consider Kmax if the difference between Km and Kmax more than 1 diopter. But in this case, we have to know why there is a difference between Kmax and Km more than 1 diopter, because usually the difference should be not that much. Usually, the Kmax is more than 1 diopter difference in relation with the Km when there are artifacts like dry spot, as you mentioned, dry eye, maybe misaligned. So you will find that there is a on corneal surface or in the cornea itself, which makes this difference very high, or ectatic corneal disease as well. So in usual cases, there will be no much difference, and we have to apply on KM.
Yes.
You apply on KM for myopic, you apply for the flat K or for the KM?
Yeah, I made the calculations, and I found that the easiest way is to take the spherical equivalent, and apply the spherical equivalent on the mean K or average K, rather than applying the sphere on the average, the sphere on the K1 and the astigmatism on the K2, the spherical equivalent on the KM.
Okay, this is the point of key reading. The second point is, in this case, against laser vision correction, the thickness. The thickness is 488 in the right eye. Well,
Yes.
the left eye, it's okay, or the same, the thinnest location.
The thinnest location in the left eye, same, 487, while the right eye, 488. So it is a thin cornea. But many colleagues may think that since we are not ablating the center, why not to make a flap, 100 microns flap, and we are not ablating the center, we are ablating the periphery. This is one point. The other point, this group of let's say, of colleagues say, why to treat the full amount of the +6? We can, since it is amblyoptic eye, we can treat +5, for example, and in this case, we will not end up with more than 49 km. Correct? So they will fully correct the left eye, and for the right eye, undercorrect, since it is already amblyoptic. So what do you say? I want to hear your opinion about this point. Do you make LASIK under 500 microns, even if hypermetropia is not going to ablate the center? And in this case, do you undercorrect since the right eye is already amblyoptic to avoid induction of high K readings? Your opinion, please.
In my opinion, Dr. Mazen, undercorrecting in a hyperopia is a little bit risky, because hyperopia by default usually tends to undercorrection by default. So undercorrecting from the start, it's not a very I don't really be comfortable of doing this. For the ablation of a case under 30, under 400 and I think 490.
Yes.
The internet is unstable.
Yes.
Dr. Mahmoud? Dr. Mahmoud?
Okay, meanwhile, we can...
we missed your question.
Yes.
Yeah, we missed your comment. Please.
Okay. Undercorrection of high hyperopia, I am not comfortable doing this, because by default hyperopia tends to undercorrect.
Yeah.
Yeah.
So let us assume if you do +5 hyperopic correction, usually will end by having an undercorrection or regression of +0.5 or +3.75 of a regression, because regression hyperopia is more significant than in myopia. Now, the most important issue that Dr. Mazen have said, do you make LASIK in hyperopic patients in less than 500 microns? In a patient who is almost 40 years of age, and I will do him femto LASIK, yes, I can do in a case like this.
Because of the thin and accurate
Regarding very important issue here, that the what?
Yeah, okay. You will go for the femtoLASIK here in such case because of the accuracy of the flap thickness and the thinning, the thin flap.
Yes.
Okay.
But in the left eye, I'm very encouraged. Actually, in the right eye, I'm not sure, Dr. Mazen. It is a very difficult case to ablate. Yani +6 diopters in the right eye, I don't feel comfortable doing +6 here.
Yeah.
Dr. Yasser might have another opinion.
Yes. So in this case, I will do LASIK. I will do femtoLASIK for this consideration. The first consideration is in this pentacam shows that this is no keratoconus in this case. It is symmetric. There is an antiomorphism, and we can supply with other examination like biomechanics or epithelial mapping and be sure that is not keratoconus. The second thing, for the right eye, it is not +6. Because we have a small of minus astigmatism or for 0.75. So if we convert to plus astigmatism, we will have +525 for sphere. And if we multiply with the 1.2, we'll have +6.3. And in this case, if we add 6.3 to the Kmax, we will have 49 diopters in Kmax, and it is acceptable, I think. In doing LASIK, I will try to center on the visual axis and not on the pupil. And I think in this case, we can go for LASIK even in the pachymetry is less than 500, as we will not ablate in the center. I think I will do it. I did some cases like this, and I will do LASIK in this case, no problem.
Dr. Magdi? Thank you, Dr. Yasser.
Thank you.
It's okay. It's okay, but for me, usually hyperopic LASIK more than 4, the results are not satisfying. For the left eye, it's +3, it's okay, but the +6, I don't think the patient will be happy.
Okay, sir. Dr. Mazen, are you here?
Yes. Okay,
good.
good.
What about the best corrected of this patient if you tried +5 instead of +6? I think this will be a turning point. If I put +5 instead of +6 for this patient, the best corrected visual acuity is still satisfying. There is a far difference between both.
Let's assume it's 0.2. So does it make any difference?
0.2 logmar in visual acuity.
Decimal.
2 lines means 2 lines. 0.2 instead of
0.3. So one line.
Just one line.
Yeah.
About the quality of vision, it's muchly different. I will consider +6. If not, I will go for the undercorrection to treat the hyperopia and get the optical benefits from the laser vision correction in such case, because we know that the patients with hyperopic spectacles are suffering from the optical aberrations with such errors. But we are assuming that this patient is not comfortable with the glasses, so seeking for refractive surgery. So if we agree that the thinnest location is 490, I will take it as a cutoff point. If it's not different as 2 microns, if not different for a colleague to take, the PRK is excluded because of the bad results or the not satisfactory results after the PRK in hyperopic patients. But I will do the same for the femto flap and correct +5, not
great.
not +6.
Remember, this is a hyperopic patient in the presbyopic age.
Yeah. Okay. Presbyopic age, he will benefit a lot from the correction for distance.
Yeah, especially with the creation of spherical aberration with the hyperopic treatment, there will be the cornea becomes prolate, and this will or hyperprolate even, and this gives him depth of focus. But now let me highlight a point in this case regarding LASIK, if I want to do LASIK.
Yeah.
Okay. First of all, if I want to do undercorrection in the right eye in order to avoid getting more than 49, then undercorrection will leave the patient with anisometropia again after the operation. And we don't know this anisometropia will, what this anisometropia will do after the operation. Maybe it will decompensate the convergence, and maybe the patient will convert from esophoria into esotropia or something else.
Yes.
This is one point. If we want to do LASIK, apart from amblyopia, let's say that this is straightforward for LASIK. This large angle kappa, of course, we have to do offset pupil or recentration of the LASIK profile with the visual axis. So we have to consider angle kappa, which is around 350 microns, which is quite large. And at the same time, we have to do decentration of the flap at the same time. Otherwise, if we cut the flap normally and we do the laser profile decentered, then big part of the laser profile will hit out of the bed, and we will end up with irregular astigmatism and endothelial cell and epithelial ingrowth later. So if we want to decenter the flap as well, it will be a large decentration. So we have to consider if the white to white is small and we are decentering the flap, then we are cutting the limbus, which will cause bleeding and will cause scarring in the future. So personally, with such large angle kappa, I don't treat the patient for hypermetropia. Especially with hypermetropia, we need to make the optical zone 7 millimeters. And of course, the flap cut should be more than 8 millimeters. With the small white to white, especially that the patient has axial hypermetropia in the right eye, which means white to white is small. So in this case, I avoid. In addition, usually I don't treat more than +4 with LASIK. I may go for a lens-based treatment. So these are my points about this. So shall we move to the last case?
Lens-based or clear lens extraction?
Yes, although I'm not a big fan of this operation.
With monovision?
Well, this depends. I have to do some tests, of course, to the patient to check maybe trifocal in the right eye, in the left eye, sorry, and monofocal in the right eye, which is the amblyopic eye.
Okay.
A question for Professor Sinjab. Will you go for LASIK if there is no problem of angle kappa in this case?
Yeah,
yes, but usually I don't go more than +4. Usually I don't go more than +4.
Don't undertreat in this case, undertreat the right eye, no?
Either I full correct or I don't do, because I have some experience, bad experience with such cases when there is a remaining hypermetropia in one eye, there will be decompensation of muscle balance.
Yeah.
Okay. Either I go for complete and full correction, or I don't. I do agree, Dr. Mazen.
Yeah.
Okay, sir.
Please carry on, Dr. Mazen, please.
Yeah. This is the last one. 25-year-old male, stable refraction, family history of keratoconus. There is family history of keratoconus. The patient has constant eye rubbing, steroid sensitive, and that gave him constant because of the eye rubbing, like topical steroids, and he developed high pressure. And then the doctor told him, don't take steroids anymore because you have sensitivity. However, eye exam with a normal limit, including ocular surface, IOP, and dilated fundus exam, mesopic pupil is 5.2. So we have young patient. He has constant eye rubbing. He is sensitive to steroids.
Sensitive
His
means
refraction
steroid
is minus
responder.
1.5, minus 2 at 10. Yes, what did you say?
No, I mean that steroid sensitive means the steroid responder, increased intraocular pressure. This is the meaning.
And sorry?
No. Two questions about the last slide. Steroid sensitive
Hello?
means steroid responder.
Hello?
Yes, sir. I can hear you. Can you
Yeah.
hear me? Yeah. Okay.
Yes, yes.
Yeah. Okay. Steroid sensitivity means steroid responsiveness.
Responsiveness, yes,
Yeah.
exactly.
Okay.
So minus 1.5, minus 2 at 10, minus 175, minus 1.5 at 170. Visual acuity is 10 over 10 or 20/20. Now this is his corneal topography in the right eye. As you see, Km is within normal range, Kmax 47, 45, so nothing important. The elevation maps are normal. As you see, there is like dome shape on the thickness map.
Yes.
Very
We missed the last comment. We missed the last comment.
that makes you uncomfortable.
Dr. Mazen, we missed
Yes,
the last
yes.
comments. The last thing we heard, the dome-shaped pachymetry map.
Yeah, exactly. So we can say that it is enantiomorphism. Enantiomorphism, because similar shapes in both eyes.
Yes.
But however, we can classify this as abnormal anterior curvature map. But other maps, the elevation maps, are normal, as you see. So this is right eye and this is left eye. So as you see, this inferior hotspot makes you uncomfortable.
Yeah.
So the first question, do you think about excluding sources of false findings? Always when we find any abnormality in the corneal tomography, we have to exclude factors causing false findings, false positives, false negatives.
Is he a contact lens user, Dr. Mazen?
No.
He is not. Okay.
Yeah, this is one of the factors, yes.
We were talking about the form frost. Can we call this case a form frost keratoconus?
Actually, this entity is classified as keratoconus suspect.
Yes.
Keratoconus suspect is not a suspect of keratoconus.
Yeah.
Okay?
Yes.
It is not keratoconus, but this entity is called keratoconus suspect, which is similar to form frost, but the difference, usually in form frost, the other eye is keratoconic, real keratoconus. But in keratoconus suspect, either the other eye is normal or it may have the same abnormality. So according to the classification, it is keratoconus suspect.
Okay, but we have two factors here. We have 2 points: the steepening, the inferior steepening, especially in the right eye, and also the large y coordinate. The y-axis is larger than.
No, we have another issue also, the family history.
Yeah,
the family history. You said
family history and eye rubbing.
Yeah.
Yes.
But
not comfortable at all.
Yeah.
For the X and Y coordinate of the pupil center, what about the other eye, Dr. Mazen?
-1. -1 point.
Yeah, this is
point some.
No. The pupil center.
The
Yeah.
pupil.
The pupil.
The internet is unstable.
Misalignment.
Yes.
Yes, there is misalignment. It's 0.08 and the other one is 0.22.
This is misalignment?
Hello?
Yes. Hello, Dr. Mazen?
Sorry?
Hello, yeah. The last question. This is
Yeah.
misalignment.
No misalignment. There is no misalignment.
Okay.
So let me say the factors, usually the factors that we have to exclude. Contact lenses, misalignment, large angle kappa, tear film disturbance, for example, dry eye, posterior surface astigmatism if it is high, corneal opacities and pathologies, previous corneal surgeries, early cataract, bad exposure to the camera, and pregnancy. We have to exclude the 10 factors before interpretation of this cornea. However, we excluded everything and the cornea is still the same. So it is really something suspicious. So what shall we do?
Yeah, this is, as you said, this may be a keratoconus suspect. We suggest this from the family history, from the history of eye rubbing. Still, the patient is young. So for this patient, I think follow-up is recommended.
Yeah.
And also, he's a steroid responder, so
yes.
we cannot perform PRK, as you said, Dr. Mazen.
Yep.
So it's wise to follow up him for a while, if you don't mind.
Yep, great. Of course, this is BAD. It is green, which means that the elevation maps are very normal. Because of course, you know, the BAD depends on the elevation maps. It doesn't take into consideration the corneal thickness or the curvature map. So BAD is normal. Wavefront, as you see for this patient, shows higher order aberrations. The RMS of the total high order aberrations are 0.47. And for the left eye, it is 0.4. So we don't do, so let's conclude for this case. We don't do laser for the patient, correct?
Yes.
Now, if the patient is not.
Epithelial mapping first.
Yeah, good. Now, if the patient doesn't have steroid, he is not responsive to steroid. I mean, he is fine with the steroids. Do we go for PRK?
In presence of this family history of keratoconus, I have to follow up first for at least 1 year. If there is no change, but I have to stop eye rubbing first.
Exactly.
I have to treat the predisposing factors, the allergy and the stop the eye rubbing, and then I follow this for 1 year to respect the family history, and then if there's nothing, I will think later in the refractive surgery. But also, because Dr. Yasser Rifay has the MS 39, he can do epithelial mapping, but we don't have.
Yeah.
But
now, actually,
yeah,
it's very important to stop eye rubbing and.
Yeah. The internet in Dubai is unstable. Hello, Dr. Mazen? Hello? Hello?
Yeah, you hear me? Yes?
Yes, now can hear you, yeah.
Yes?
Again.
Hello?
Yes, okay. See your comment again?
Yeah, you can hear me?
Yes.
Yes.
Yeah, I say that, believe it or not, after you stop rubbing, many patterns like this one will disappear. The cornea will return to normal.
Yeah, perfect. I believe you because the eye rubbing is a mechanical ectasia.
Exactly.
Yeah.
So
but do you have,
this is the last case.
Do you
any
have
questions?
Images? Do you have images for this case after stopping the rubbing, or you are expecting that? Okay.
No.
Okay, sir, but here 2 points
Thank you.
are very important: the epithelial mapping and the corneal biomechanical properties studying.
Yes,
Yeah.
exactly.
Okay, Dr. Mahmoud.
Thank you, Dr.
Thank you
Mazen.
very much, Dr. Mazen, for the very instructive presentation. And I may call now our dear guest, Dr. Yasser Rifay, to present something about epithelial mapping.
Thank you very much, Dr. Mahmoud Ismail, Dr. Ziada, Dr. Magdi Khalaf. Thank you very much, Dr. Mazen Sinjab, for this great presentation. And I thank him also to introduce my presentation by his last case, because the last case that he presented is a very good case for epithelial mapping.
Okay, but Dr. Mazen has to quit. Yeah. Yes. Okay.
So I will.
In the center of your screen, yes.
Can you see now?
Yes.
Yeah.
Perfectly.
Okay.
Yeah.
So thank you very much to give me the opportunity to present these cases about epithelial mapping in corneal refractive surgery risk assessment. So the first case is a female of 20 years old. She's asking for refractive surgery. The refraction is -2 right eye and -1.5 in left eye. The best with astigmatism. The best corrected visual acuity is 10 out of 10 in both eyes. So this is the topography, the pentacam for the right eye. And this is the pentacam for the left eye. So what will you do? I will show another time the pentacams. Will you go for LASIK, PRK, or nothing? Do not give importance to the age. You can say for 25 or 26 years old. We give importance to the images we have. So with this case, will you go for PRK, for LASIK, or for nothing? For -2, don't think of the age, okay? So I ask the panel, what will you do in this case?
Dr. Magdi, do you like to add something?
Yeah, it's okay. I can see skewing of the axis here, the right eye and the left eye also. This is very clear. I think this is more than the acceptable. How much is the astigmatism, Dr. Topographic astigmatism?
1.5. The topographic astigmatism is in the right eye 1.7 and the left eye 2.3.
Yeah, I think with this skewing, it's significant skewing. For the left eye, I can see inferior steepening. Actually, I can't read well the numbers, but because it's very small, but
I will give you this. This is right eye.
The
right eye.
For the right eye, yeah, the skewing is very apparent. The thickness is not concentric well, but let me see the left eye, please. The left eye, yes. There is steepening. There is difference between the inferior and superior of around two diopters together with the skewing. So I actually I don't go for LASIK for this case.
It doesn't have a wide angle kappa also, Dr. Rifai?
This is +6. This is maybe a small misalignment. No, the X is not the same in the both eyes, but there is asymmetry. It's vertical asymmetry. So I will go ahead. We have this rax. We have this abnormality. We have the asymmetry that is more than 1.5. We have this abnormality, but this is with the MS39. This is the anterior sagittal map. We have this asymmetry in the left eye. It's confirmed. And let's go to the epithelial mapping. In the epithelial mapping, we have here a thickening in the area of the steepening. We have here a thickening of the epithelium in the right eye, and the same thing we have here, a thickening in the epithelium, and you have the colors of the epithelium. It's going from the thinnest to the thickest. There is no donut, and where there is no donut, sometimes people are rubbing, and there is a displacement of the epithelium to the inferior side of the cornea, and we will have this asymmetry. So in this case, there is no keratoconus, and we can see in we are looking here for scars, and I will do a discussion in the end. So in this case, following the studies of Dan Reinstein, there are a lot of studies of this. You can exclude the keratoconus in this case. So the steepening we have, the straks, it's only the irregularity of a normal epithelium. This is the first case, and in this case, with this normal epithelium, I can go for laser ablation.
If there is a keratoconus, you will find thinning instead of thickening.
Yes, we will see other cases. So in this case, I do at least a PRK. We have another case, female. Yes, PRK. Female, 26 years old, for refractive surgery, -4 in both eyes, with a very good best corrected visual acuity. And in this case, it's a little bit the same. So we have this map in the right eye, and this map in the left eye. You have, can you see them when I put them? Yes. So what will you do in this case? -4 myopia in this case. Will you go for PRK, LASIK, SMILE, or nothing?
I will do PRK also, Doctor. In a case like this, even if you have, I don't have a epithelial mapping in my facility, but in a case like this, the young patient, especially if it's female, I will go for PRK. It's in the limits of the PRK. I will be more than comfortable.
Okay.
Dr. Yasser.
Professor Magdi, do you like to add something?
I will ask for epithelial mapping.
Yeah, okay.
I don't have it.
Dr. Yasser, what about the inferior superior steepening difference? Sorry, is there any inferior superior difference at the 4 millimeter zone?
Yes.
Dr. Yasser,
Yes. In the
what's the amount of difference?
Yes. I noticed the asymmetry here. So in the pentacam, I noticed this asymmetry here. It's less than 1.5. You have a normal pachymetry. Even if there is a displacement, you have normal elevation here. In the left eye, you have asymmetry at 1.5 diopters, normal pachymetry, and normal elevation. Mm-hmm. So in this case, it's a borderline case for PRK, like the first one. Mm-hmm. Let's go to epithelial mapping. So in this case, the epithelial mapping shows a thinning over the steep area. So you have a donut here, and if you see it in the 3D, you will have this image of a thinning, and you can see it very clear here. So this is an early keratoconus. In the left eye, it's the same image. You have a thinning here over the steep area, and when you have this image, it confirms the early keratoconus. So with -4 in this case, I will not go also for PRK. I will do nothing. Maybe intraocular surgery or nothing, but no corneal laser vision correction.
You will consider, Dr. Yasser, you will consider it as a keratoconus or just a suspect?
Yes. It's an early keratoconus.
Actually, it's very difficult to consider it. I don't know. I will do PR for a case like this here, Dr. Yasser, because I don't have. Of course, I don't have an epithelial mapping to judge correctly like you did, but do you think we can diagnose keratoconus just from this image of the epithelium? You are convinced of this?
So the study of Dan Reinstein that I've done for some years, I follow all his publications. So we can and I will prove you that with only epithelial mapping you can diagnose a keratoconus. And now the image of epithelial mapping can be a criteria, a real criteria of diagnosis in keratoconus more than the anterior surface of Pentacam or other devices. I will show you why.
Oh, okay, Dr. Yasser, look, we cannot say there is keratoconus without posterior elevation problem. If the posterior elevation is normal, it is not keratoconus.
It's maybe an early one, but we will go.
So, Dr.
Yeah,
Yasser,
even early.
Dr. Yasser, on the basis of the epithelial mapping, you will go for cross-linking for this patient?
No, no, because cross-linking is for when I have anterior when I have a manifest keratoconus and progressive keratoconus. So in this case, I will avoid laser vision correction and to follow up the patient.
Was there any scissoring reflex?
I didn't look for.
You know, Dr. Yasser,
yeah.
Believe me, in a case like this, even you have a very demonstrative epithelial mapping, but I will go for PRK for several reasons. First of all, the best correction of this patient is a very good best correction, so the patient is not losing any best correction. There is enantiomorphism, so it's a mirror image cornea. The patient is above 20 years, so it's 25 years. The PRK has a cross-linking effect. So
I do not hear.
in a case like this, I don't expect any kind of ectasia. Moreover, how many cases are ectasia in my whole life? One of them is one of these eyes was done by me. And if I go back by time, yes, I shouldn't have done it. But the rest of the cases, 3 cases or 4 cases maximum, they were also done by other colleagues, and they were very high susceptible keratoconus, but not like this one.
Yes.
I don't know. I would like to ask the panelists, do you go for PRK if you see like a patient like this? Dr. Magdi, Dr. Mazen, Dr. Hossam?
There are many reasons for focal thing of epithelium here. I think, did you exclude dryness, dry eye, for example, constant
Yes.
eye rubbing?
So in this case, the anterior surface, we have done it. We have done this the topography before doing drops. We have treated the allergy, and we have done all to have these images. There's no problem of surface.
Well, in this case, if the scissoring reflex is not there, I would consider it because there is no inferior superior difference.
Doctor.
Yes. Do you hear me?
Dr. Magdi, do you like to add something? Dr. Hossam?
Dr. Mazen, go on. Dr. Mazen is still commenting.
Sorry, Dr. Mazen.
No problem.
Go ahead.
So for me, I consider this case as normal. If the scissoring reflex is absent, I consider it normal case. If the scissoring reflex is absent.
Okay.
Okay, sir. We may add the aura or the corpus to support or to exclude. If there is abnormal corneal hysteresis, it will support cornus. If not, it will. We will consider as surface regularity, just surface regularity in the epithelial in the corneal epithelium, and in this status, we will go for PRK if there is no corneal, low corneal hysteresis.
Yeah.
Dr. Yasser, you have the Bellin Ambrosio of this case?
I have it, but not here. I don't have it here now, but
I think
have only,
it should be normal. It will be normal because
because
Belen and
possible
Rosen
elevation is
depends
common. Yes.
Yeah.
elevation.
It depends
Only.
on the elevation. The elevations are normal. Yeah.
Yeah.
And there is no elevation in a case like this.
Yeah.
Okay, but
Okay,
it's a very good
that-
point of debate, yeah, Dr. Yasser الحقيقة.
Just to consider, but
I will continue. Sorry?
yeah, just to consider the epithelial thinning and then search another supporting points with it.
Yes.
Yeah, okay.
I will just present small presentation about epithelial mapping. I will answer to Dr. Mahmoud Ismail because he said that the visual acuity is 10 out of 10. So the epithelium is masking even the high order aberrations. He's doing a mask over the irregularity of the stroma. We'll see it, and we can have 10 out of 10 of visual acuity even if the stroma is a little bit irregular, because it will smooth it from the surface. And we will see the small presentation about this. So the epithelial mapping is a huge development you can imagine. The epithelium is not homogeneous, and when we have any irregular stroma, we will have irregular epithelium. It will fill the gaps, smoothen the surface. It hides some of the surface aberrations of the stroma, so we can have an early keratoconus with irregularities, but it will be hidden by the epithelium. So we'll see. This is the theory of Dan Einstein, and this case, what we have seen now is we have seen this case when we have an irregularity in the pentacam, but there is a thinning in the epithelium, and this is real keratoconus. And this is the pentacam is normal, but there is a thinning in the epithelium and there is a keratoconus. And this is a case of early keratoconus when we can have normal pentacam. And now in this case we have steepening, but the epithelium is thick. So in this case, it can exclude a keratoconus. So we have this early keratoconus hidden by the epithelium, and here a normal cornea, but hyperplasia of the epithelium due to rubbing or other problems that will give this steepening.
So Yasser, yes, would you please go back to that slide?
Yes.
Go back to that slide. Yes. So as you see in the one which is early keratoconus, you see in the early keratoconus, according to Dan Einstein classification, there must be a problem on the posterior surface.
Posterior surface, yes.
Posterior,
Yeah.
yes.
This is one point. And if you can show us the stromal elevation map, which is given by the MS39, the stromal elevation, okay? In case of thinning due to early changes of keratoconus, you must have elevation on the stromal elevation as well, corresponding to the thinning. So in your case that you presented, did you find elevation on the stromal elevation? Did you find focal?
I didn't look for it because when I see this donut, I exclude the case, but I will do it.
Yeah. Okay. Great.
When I see the donut, when I see this clear donut in both eyes, I prefer to exclude the case. But I will do a correlation between these two things.
Yeah,
between,
stromal elevation.
Stromal elevation, stromal thickness, and the epithelial mapping.
Exactly.
Yes.
So the normal the behavior of the epithelium in cases of ectasia, it is the epithelial thinning here and the thickening in the periphery. So when you see the real curvature of the keratoconus in the posterior surface is different from the anterior surface that will hide this this aberration. So here the filling effect of the epithelium in the case of scars and of irregularities. So the anterior surface that we measure with topography sometimes will not give us the reality of the stroma. The normal epithelium is like this. It's a little bit it's regular but asymmetric. There is a temporosuperior thinning because of the eyelid, and there is a small asymmetry and a thickening here, more than the superior, about 5 microns. It's sensitive to contact lens wearing, to dry eye, and to surface diseases. And the abnormal epithelium is like this. It gives the donut image. So you have the thinning over the peak, and you have the thickening around it, and you see it in this 3-dimension. This is another case of an asymmetric or decentrated cone. So you have a thinning here and a thickening. And if you see this mapping is the epithelium is like a lens, which is we try to correct the aberrations of the stroma. The epithelium is not as regular in the normal corneas. It will modify its geometry to create a small lens. It means that the epithelium is a small lens over the stroma that will try to treat a little bit of the stromal aberrations. That's why sometimes it hides the high order aberrations of the cornea. This is another case. This is a case of thickening over the peak that exclude keratoconus. So this avoids a false positive, but we have to correlate to the axial maps and to elevations, as Dr. Mazen said, and we have to pay attention if there is any scars, because in this case, you have a thickening here, and when you have a thickening here in the keratoconus, you should look for a scar, because in this area we will have a gap that will be filled by the epithelium, and we will have this feature. This is another case of we have here the donut, but you have a thickening here, and it is always correlated to a haze or a small scar, and you should always correlate the map with the other maps of the topography with the OCT scan. Another case with the fill-in effect. So in an epithelial mapping, we analyze the thinning, the thickening area, the average thickness, the shape of the epithelium, the location of the thinning, and it should be in mirror with the curvature map, because it is a way to mask and to hide the irregularity of the stroma. And we will measure also the difference between the thickest and the thinnest points that will maybe suggest an evolution of the keratoconus. And we have always to correlate epithelial mapping to slit lamp examination, high definition OCT scans, curvature maps, elevation maps like this. And thank you very much.
Thank you, Dr. ياسر. الحقيقة يعني أنت بتدينا يعني very innovative idea, but unfortunately I really disagree about the case that you have presented. I don't think that epithelial mapping can change the curvature of the cornea to an extent to suspect keratoconus in a case like this. I do agree that if you have a posterior elevation, somehow, even if the least amount, you might diagnose, and epithelial mapping can help you in diagnosis of early keratoconus. Let me remind you something. In the old days, we used to have only surface topography, anterior surface topography, and we used to rely on 2 indicators, the surface regularity index and surface asymmetric index, and that's it. We didn't have anything more. And at that time, we used to do PRK, and still we didn't have ectasia. Ectasia appeared. Ectasia is a word related to LASIK. So in a case that you have presented, if you try to present it as an early keratoconus patient, not candidate for any kind of laser, even for laser surface, I'm not sure about this. But if you tell me that this case, in coherence with some kind of posterior elevation, to be followed up as a normal patient, yes, it might end by diagnosing something, especially if there is a posterior changes. But a case like that you have presented, I don't know. if it comes to me, I will do PRK, and I'm sure that, inshallah, nothing will happen. I don't know. What do you think, Dr. Mazen? You do PRK in a case like this, even that Dr. Yasser have presented a very full defense about the epithelial mapping. What do you think?
Yeah, thank you very much.
If it comes to your clinic, a case like
yeah,
this.
exactly. Yeah. Actually, I have the MS-39, and I usually study the epithelial mapping in correlation with two things. The first one is stromal elevation. The second thing is the pattern of stromal thickness, stromal, not corneal thickness, stromal thickness. Because whenever there is a suspect or early keratoconus or whatever, there will be focal thinning in the stroma, corresponding, I don't mean focal thinning because sometimes the stroma is still thick, but I mean the pattern itself, the pattern of the thickness is like focal and displaced and corresponds to the high elevation on the stroma, so stromal elevation and epithelial thinning. So if I see these three factors are corresponding to each other's, then okay, we are facing something suspicious. And if this is associated with posterior elevation abnormality, then I say yes, it is keratoconus. If it is not associated with posterior elevation, I say this is something that I have to be afraid of, but it is not keratoconus. But if I find only thinning in the epithelium not corresponding to high elevation in the stroma, not corresponding to the focal pattern, do PRK comfortably.
Yes, repeat please, Dr. Mazen, at the last sentence because the connection was cut. You do PRK comfortably?
Yes, if I find only epithelial thinning, I do PRK comfortably.
Okay.
So
Dr. Hossam, Dr. Magdi, do you like to add something because we have running late, very late actually, and it's very late in Dubai for also with Dr. Mazen.
Yeah, we are very close in Dubai to the done. So Dr. Magdi, we have now internet problem. So we will set a point just to, as a conclusion of this discussion, that the keratoconus will start posteriorly before going anteriorly. We have to find a posterior elevation changes or abnormality before finding an anterior elevation or anterior surface abnormality in the case of keratoconus. So we have to correlate both together, as we said, as my professor said.
Actually, this is a very good point and a very good question to ask to Dr. Yasser.
Yeah.
In the cases like this, Dr. Yasser, that you suspect that this is keratoconus, actually is a very good point to study because you want to prove that this kind of donut is actually as an alarming sign for keratoconus. So you have to make serial imaging with or without the posterior elevation maps that you have.
Yes.
But really it's a very new world actually. يعني ده كله عالم جديد بالنسبة لنا. Epithelial mapping is a very tentative field.
Yes.
And I really thank you for your nice presentation and your nice talk. Dr. Mazen, thank you very much for your effort and for your presentation and for discussion. Professor Magdi Khalaf, thank you very much. And thank you all. Thank you, Hossam. Thank you, Dr. Muhammad Eid and Dr. Hatem for concluding this session. And we are looking forward for more and more meetings and more collaboration with you, Dr. Yasser Rifay. And by the way, Yasser Rifay is a very Egyptian name.
Yes.
I was suspecting that you are Egyptian, but you are hiding in Morocco somehow.
Okay.
No, Syrian name.
And also Syrian Yasser Rifay.
area.
Thank you, Dr. Mahmoud, for
Thank you very much.
discussion.
And
Thank you, Dr. Mazen.
مرحبا بكم في رحاب الازهر والجمعيه الرماديه المصريه 1902. شكرا لكم، الف شكر. Thank you very
شكرا
much.
جزيلا. ندعوكم الى السحور في دبي الان، صار عندنا وقت السحور.
يا طبعا فاضل ساعه على الفجر، صح؟
صح.
بالهنا والشفاء. Thank you, Dr.
الله يبارك
Mazen.
فيك.
Thank you, Dr.
شكرا يا ياسر
Yasser.
بيه، الف شكر يا ياسر بيه على تعبك ومجهودك، وقومناك من على الفطار، معلش احنا اسفين يعني.
شكرا الف مرحبا.
الف شكر يا ياسر بيه.
Thank you, my friend, Dr.
بأمان الله.
Thank you, Professor Mazen,
شكراً.
for making our meeting successful and beneficial for all. Thank you very much.
Some of our colleagues is telling you ألف هنا وشفا يا دكتور مازن.
على قلبكم جميعا إن شاء الله.
Okay,
نستودعكم الله جميعا. السلام عليكم
السلام
ورحمة الله
عليكم.
وبركاته. مع السلامة. مع السلامة.
عليكم السلام.
Salam, Dr. Yasser.
تمام.
And take this point to work on. Okay, we will discuss it later.
Can I end the meeting now, Dr. Hussein?
Yeah, okay, Dr. Magdi joined us again. Thank you, Dr. Magdi. We are sorry for the internet instability. We are thanking you so much for making the discussion fruitful and beneficial for the all audiences and for us as well. وتصبح على خير يا فندم وسحور سعيد.
شكرا لكل اساتذتنا.
السلام عليكم.
وعليكم السلام ورحمة الله.
رعاية الله. مع السلامة.